in your experience, you have operated on a lot of GBM,
yes.
right? Can you tell us the procedure?
So the procedure first, of course, is to do an MRI. And nowadays, like I mentioned earlier, we do resting fMRI, particularly if the tumor is in an eloquent area, like near the area of the brain that controls movement or speech or sensation or vision or hearing. Then we want to understand the networks around the tumor. Then we plan a trajectory. Today's day and age, we use a lot of advanced systems to ensure that the outcome from surgery is good. Why do we want a good outcome from surgery? There are two things we need from surgery. We need to remove as much of the tumor as is safely possible. And we want to preserve the patient's function. Because for the patient to undergo adjuvant therapy, like radiation and chemotherapy, the patient should have preserved function. I can't expect a patient who's hemiplegic to go for radiation therapy.
Who cannot move his arm and leg to go for all these advanced treatments.
Or it may worsen the edema in the brain also. So the whole goal is to do targeted, highly precise, extirpative surgery to achieve maximum resection as safely as possible. How do we achieve maximum resection? We use something called navigation. So we take the patient's MRI images and we load it onto a system in the OT, which is like a GPS. So that networks which are mapped on the patient are also mapped on the MRI and it's shown to us on the patient when we are actually operating. To see where the networks are. So we can avoid those areas, because if we enter into those areas, if we stray into those networks, we are going to cause impairment in function.
Just taking a step back. So we are talking about opening the head.
Yes.
We're talking about craniotomy first.
Craniotomy.
And how do you do the craniotomy with a saw?
So we have a sophisticated drill system.
I mean, just for layman term, it's basically you just have to cut down the hard skull.
Yes. So what we do is we create something called a hole, a burr hole. So we make a hole in the skull. So the skull actually has bone, which has an outer table, inner table, and in between it has cancellous bone. So we go all through up to the inner table, and there's a covering over the brain. We don't disturb that covering. And then we put the saw. The saw is an L-shaped blade and it cuts only on one side. So we take that saw through the hole and then we cut the bone in the line that we want. And then we join that line to the original hole. So then we get a piece of the bone. That bone is kept aside, it's covered, kept sterile. We open the covering of the brain. And the planning of the craniotomy is done with the navigation. So how big are we making sure we're doing it in the correct place? We're ensuring that we have adequate access to the tumor. Then we open the covering of the brain and we reach the tumor. Many tumors are on the surface of the brain. Some are underneath the surface. So then we have to cut through the brain to get to the tumor. Then again, where to cut, how deep to cut, how to avoid all the important fibers. All that information comes from our preoperative MRI imaging and our navigation. During surgery, we can use various techniques to remove the tumor. Most of the time we use bipolar coagulation, suction. We can use sometimes CUSA, which is ultrasonic aspiration, which is also used in liver surgery. And then we use something called fluorescence. So we inject a dye, and when we inject that dye goes and gets deposited in the tumor. Then during surgery, we can turn on a particular filter in the microscope, which shows us only that dye. So we can make out the difference between normal brain and the tumor.
Tumor localization.
So make sure that we maximize the removal of the tumor. We don't leave anything behind. In addition to all this, there is something known as awake brain surgery. So in certain cases where we are worried about patients' function getting disturbed, so if the tumor is in the speech area or in the motor area, we may decide to keep the patient awake during tumor removal.
So patient is awake during brain surgery?
Yes. That we do only when it's absolutely required, particularly when we're trying to monitor speech. Because speech is one thing that we cannot monitor with any other method. So we can use neuromonitoring, cortical stimulation during normal brain surgery, where the patient is not awake, with some modified anesthetics. But in some cases, we want the patient to be awake. So when we are on the tumor, and we want to make sure that we're not straying into an important area like the speech area or the motor cortex, we will ask the patient to be awake and we'll ask them to be performing certain actions. So if you go to YouTube or Google, you'll find some instances where patients have played the violin during surgery, or some people have sung songs during surgery, recited poetry and so on. Those are all examples of awake brain surgery.
Wow.
Now, the reason why that is possible is because the brain itself does not have any pain receptors. So you can cut through the brain, you can dissect the tumor, and the patient will not feel any pain.
Wow, damn.